Welcome to the ESC TD in Barcelona ESC 2022 Congress. My name is Riccardo Stagiano. I am the past chair of the Council of Cardio-Oncology of the ESC, and I have the pleasure to introduce these sessions about anthracycline-induced cardiotoxicity, what cardiologists may do about this issue. I have the pleasure to introduce Professor Lopez Fernandez from Madrid and Professor Borja Ibanez from Madrid. So a very Mediterranean session. And we will face during this session the problem of the anthracycline cardiotoxicity and also the issues related with this problem, about prevention, about diagnosis, management, and the possible developments about the possibility to avoid this cardiotoxicity that are the main topic of the resilience trial, probably the biggest trial about a cardio-oncology topic that has been the recognition of be part of the EU 2020 project, receiving funding for this research. So without any doubt, I will leave the lead to Teresa that will explain us something about anthracycline-induced cardiotoxicity. Please, Teresa.
Thank you very much, Ricardo. So, as you know, anthracycline is one of the oldest cancer treatments and is frequently used in our clinical practice for breast cancer and patients with lymphoma. And we know that it may lead to myocardial damage and left ventricular dysfunction. And this cardiovascular toxicity related with anthracycline may occur anytime. But we know that it's most common during the first 12 years after cancer treatment. And the main problem we face with cardiovascular toxicity is that when cardiovascular toxicity occurs during the cancer treatment, we sometimes need to stop cancer treatment, and this affects severely the prognosis of our patient. So we just have released the first ESC guidelines on cardio-oncology. And the aim of this guideline is to present the cardio-oncology, this cardio-oncology new area as an opportunity to minimize the risk of cancer therapy-related cardiac toxicity and also to minimize the risk of unnecessary cancer treatment interruption. So we need to work in the pre-treatment phase. We need to improve our tools for baseline risk assessment, but also to understand which are the best cardioprotective therapies for these patients. And I think that resilience is probably one of the trials that is going to answer most of our clinical questions about cardio prevention. What you can explain us?
Yes, thank you very much, Teresa. So, as you know, much better than we do because you are the chairperson of the recently published cardio-oncology guidelines along with Professor Leon. So, anthracycline-induced cardiotoxicity is a big problem. So, more or less the prevalence is estimated in 1 million European citizens living with chronic heart failure who have survived cancer, which is a major trade-off, surviving cancer but have to live with a chronic disease. At these days, there is no effective treatment to prevent anthracycline-induced cardiotoxicity, and therefore there is a clear unmet clinical need. So the bottom line or the background for this European Union Horizon 2020 funded project was some studies performed at the experimental level in which one therapy was identified to be extremely cardioprotective, and this was remote ischemic conditioning, which, just to briefly explain, this has been tested many times in other clinical scenarios like myocardial infarction and stroke, and it's a pretty simple, non-invasive intervention, which is entailed by a blood pressure cuff, which is inflated for 5 minutes, then is released for 5 minutes, and then this is repeated for 4 cycles. So there are some release of some protective factors that upon the exposure of an injury, in this case anthracyclines, can protect the heart from developing injury. The second background preliminary data that we use for this project was the identification of a potentially new early detector of cardiotoxicity, which was based on magnetic resonance imaging, which is the significant prolongation of T2 relaxation times, which by pathology was associated with the development of intracellular edema. And also there was a third background data, which was the development of a novel CMR sequence in which patients could undergo the complete CMR study rather than 45 minutes in less than 1 minute. So this was especially suitable for vulnerable patients like cancer patients. So having all this in background, we applied for the European Commission and we were funded. And it's a consortium that is composed by a very complementary group, cardiologists, cardio-oncologists, hematologists. Also we have the participation of the European Society of Cardiology. We have Philips participating in this imaging part. And as I said, we also have the participation of patients, Lymphoma Coalition Europe. So in summary, what we're going to perform is to enroll 600 patients in 6 countries with lymphoma, because they receive a pretty consistent and standard treatment, including high-dose anthracyclines. And they have high risk for developing cardiotoxicity because they have any risk factors associated with this. They are going to be randomized to remote ischemic conditioning, which will be done by the patients themselves at home. So they will bring the device at home and they will perform weekly remote ischemic conditioning, and control patients will have a SAM procedure. All patients will undergo 3 magnetic resonance imaging studies, baseline, halfway chemotherapy, and 9 weeks after finishing the chemotherapy. And the primary outcome of this study is the incidence of cardiotoxicity events and also the reduction in left ventricular ejection fraction. Also, we'll validate this novel marker, because if we are going to have several CMR studies, we could see that patients who develop cardiotoxicity, whether they had this biomarker or this imaging marker altered early, and we would compare this to classical markers like troponin, BNP, and so on.
In the guidelines, we try to involve also the patient, and this is an essential issue for instruct the patients about the possibility to have induced cardiotoxicity, about the symptoms, about the possible strategies to avoid cardiotoxicity. Also, the Resilience Project has a strong program for patients' empowerment. May you show something about this?
Well,
both.
I agree with you, and I think that it's really, really important to educate patients on their risk, and also try to help them to promote healthy lifestyle during the cancer process. And in fact, in our guidelines, we incorporate the patient's voice, and we are going to organize a specific guideline summary for patients that focus on the key general preventive measurement that they can implement with their family and caregivers to reduce the risk of cardiovascular toxicity. But I think that the cardioprotective strategy that Resilience wants to implement has several advantages over other, let's say, more standard cardioprotective strategies, because when we try to prevent anthracycline-related cardiotoxicity with beta blockers or with ACE inhibitor, and in some very high-risk patients it works, but sometimes we have problems with blood pressure, with heart rate, with the tolerance, and patients are already under a huge number of medication. So we have also to deal with the drug-drug interaction problem. So the fact that you can implement a cardioprotective strategies without drugs, and giving the power to the patient to really participate in their own care, I think is amazing.
Yes, I completely agree, and I think that one of the key differential aspects of Resilience is that it's a patient-centered project. Patients are participating very actively in the project. They have been involved in the design of the study. We are going to measure patient-reported outcomes and experiences, which is extremely important as the hard outcomes that we measure. And also, as you said, it's very important that the intervention is non-invasive, so it's very good for all the aspects that you have mentioned. But also, it's very important that the patient is going to be responsible for giving him or herself the intervention. So I think overall, the patient-centered approach of resilience is clear in line with the recently published guidelines and with the approach of the entire European Society of Cardiology.
Well, I think that this is a very important issue, and this is one of the novelty points of this trial. I think that never patients have been involved so in depth in a project, in a research project as in this way, and this is very important. So I think that this is a very important issue, the anthracycline-induced cardiotoxicity. We have a lot of other cancer treatment that may be a target for similar interventions. So it could be a beginning of a long, very long history, and we have a very long road before us. I would like to say something more from guidelines to practice. Teresa, would you like to add something about this?
Sure, thank you.
For example, the evaluation of the risk of the patients. May we say something more about this specific issue?
Yeah, thank you, Ricardo. I think this is a really good point because we promote in the new guidelines personalized cardiovascular surveillance during the cancer process. And it's impossible to do that if we don't assess the baseline cardiovascular toxicity risk. And there is another important issue that is, I think, a new thing in our guidelines. This is that we include the new definition of cardiovascular toxicities because we need to try to implement the same language to adjudicate events. So I'm really interested on which is the procedure that you have implemented in the resilience for events adjudication, which is critical to analyze the results,
yes.
Of course.
So you are absolutely right that first of all we have to harmonize the definition of cardiotoxicity, because these days cardiotoxicity can be many things. Even if you are only discussing about the reduction in systolic function, also there are many definitions. So for this project we wanted to use the most updated definition of anthracycline-induced cardiotoxicity, which is a reduction in ejection fraction of 10 points or 5 points to an ejection fraction below 50%. But also I think it's extremely important that we are able to, as we mentioned, to harmonize and to be able to later on compare between different trials. In terms of adjudication of events, you are absolutely right that it's critical, because it's very important that all the events are adjudicated independent and blinded to the treatment allocation, and this is what we're going to do in Resilience. We're going to have an adjudication committee for my hematologist and cardiologist, and they will evaluate the events independent to all the other information.
Yeah, in fact, this
another very important issue of the resilience trial is the looking for a new evaluation method of the patients through MRI. That is quite a novelty, because generally in cardio-oncology we are speaking of echo, of strain and so on. Once upon a time we were pointing on nuclear methods, and now MRI. And this I think that is very, very innovative. But what may be the costs?
Well, this is a very good point. I can advance, and maybe we can get also the insights from Teresa. So for this project, we are doing a very comprehensive CMR protocol, which is not only the regular CMR, but also we have very novel sequences. Some of them are not even in the market yet. Some others are mapping, so we are going to be able to evaluate anatomy, function, and also composition of the tissue. But of course, we know that this is not going to be available for every single patient in the future. So I think it's very important that we're able to do, as Teresa mentioned, a personalized medicine approach from the entire bulk of patients undergoing anthracyclines, which are the most in which we have to take care, and then from those, which are the diagnostic tests that we have to perform. And they would be able to identify those who would benefit for this approach based on magnetic resonance imaging. And also we envision a future in which not only we are going to use this in order to identify cardiotoxicity, but eventually we can identify which patients might even receive higher doses of anthracyclines, which is something that is today a big problem, especially in cancer relapse, and we might use imaging for this purpose. I don't know if, Teresa, you think that this would be something feasible?
No, definitely. I think that this is a great challenge you face, but you are going to have the possibility to answer really key questions in the cardio-oncology world. So I think that we can help a lot of patients with this initiative. So congratulations, Borja.
We, because we are all together part of this big study.
So I would like to thank you both for this very interesting session. I think that now we probably may say that have beginning a new era of cardio-oncology with the resilience trial. Would you like to add one word for summarize the issue of the session?
Well, I think
bye-bye.
That's bye-bye is a good option, but please read the guidelines and try to share these guidelines with your oncologists and with your hematologists, and try to implement your local protocols, because you are going to discover that it's not so complex, but if you pick the right patients and you organize the right pathways of care, you are going to improve a lot the life of your patient.
If maybe I can share that I have a dream. I had a dream that eventually maybe in the next future, when there are new guidelines, eventually what we are doing these days with a very comprehensive and well-performed clinical study, eventually this might have an impact on clinical guidelines in the future. So this is why it's very important to do clinical research, very good design and executed studies, because in the end guidelines are based on studies, and the best performed studies, the best evidence for the guidelines.
So we are waiting for the results of this trial that will be ready in a couple of years, more or less, and we hope to see you next year for updating you about the resilience trial. Bye-bye.